Okay, cool. So, good evening, everyone. Let's start with some SBAs to kind of get it flowing. So we're starting on the urology front. So a 32-year-old female presents with a one-day history of left-sided loin to groin pain, which comes and goes in waves, and one episode of visible hematuria. She's currently afebrile. Blood pressure is 125/85. Her heart rate is 105. Given the presentation, what is the most likely diagnosis? So I don't have Menti or anything, so just pop your answers in the chat and we'll go from there. Okay, so we've got one for C. Yeah, nice. So it's very unanimously C, and this is, yeah, the most sort of classic presentation you're going to get of renal calculi. Can anyone give any indication like why? Because I think sometimes people between pyelonephritis and renal calculus, what were the things that kind of told you it was renal calculus over pyelonephritis? So yeah, the fact is this kind of coming and going pain. If they've had pyelonephritis, it might be a bit of a longer history. They get this colicky pain and then they get worse and they get, febrile. And the fact that she's a bit tachycardic is probably that she's in pain. And so don't let that kind of throw you into like, is this a kind of sepsis thing? She's got like her blood pressure's fine. So it's probably like the pain that's giving her that rather than an infection. And yeah, like that's the main kind of thing we worry about with renal stones. Perfect. And then yeah, with UTI, it's not loin to groin. It's going to be more suprapubic. Renal cell carcinoma, there's going to be a long history, some weight loss, that kind of thing. And then an AKI can be a consequence of renal calculi, but it in itself wouldn't cause this pain. Cool. So urinary tract stones. So it's more common in males than females. Caucasian males like have the highest risk, and it's typically in this kind of middle-aged group. It's a very common presentation to A&E. You'll see it a lot on your A&E placements in final year, especially. And most of them you can pick up on an X-ray. Some of them you can't, and we'll go through those in a second. And the commonest sites, so I've kind of circled them here. It's kind of where there's a natural it's just got a naturally smaller diameter. So the pelvico-ureteric junction is one, and then down here at the vesico-ureteric junction. So just don't get those like confused, because sometimes they might give that as a description as to where it is. And obviously if it's up here, it's going to give more of a loin pain, and whereas this, they might give almost like a left iliac fossa pain or a right iliac fossa pain, and it may radiate, to the flanks, but just to bear in mind that might also change the location of their pain. And generally, like without treatment, this is very likely to recur. And so we like to give some good treatment. So does anyone know, like, can anyone name some types of stones that patients can get? And let me know which one you think is the most common type. So yeah, good. So calcium oxalate. Struvite is always the most memorable one. Yep, urate is one of them as well. Fantastic. So calcium phosphate is almost the most common, but it's actually the oxalates that are the most common. But calcium phosphate is probably like second. And then, so I think you've basically hit like the main ones. The other ones are very rare. I think they'd be unlikely to come up, and just be a bit aware of them. So yeah, like cysteine is one of the ones. So with types of stones, so 75% are calcium, and that's calcium phosphate, calcium oxalate. Struvite they might call them triple phosphate stones, and they're 15%. And then cysteine you get in the context of homocystinuria, which is one of the inherited defects in metabolism. And the only thing I would really remember about that is they can look marfanoid, but they don't have marfans. And they can get lens dislocations in the opposite direction to marfans. That's kind of about it. I wouldn't say you're expected to know much about it, but I think if you get a stretch question that says, you know, a man of marfanoid habitus presents with like loin pain, what is the most likely stone? It's going to be cystine. And then urate is going to be in your typical patient with high uricemia, so they might have a history of gout, or it's people who have had chemotherapy recently and have tumor lysis, and you're going to get that release of uric acid into the blood. And so they're put on kind of prophylactic allopurinol and things like that to kind of prevent this happening, along with like gout attacks and other problems. And so I think the other thing that's good to know is like, so not an X-ray is not going to be completely sensitive to these because some are not radio opaque. And there's only, you know, these two that aren't radio opaque, and then struvite is kind of partial. So you can't rule it out. And obviously it's a very small stone, you may not see it. And so it's just worth knowing like which ones are radio opaque and which ones aren't as well. And then just a thing to mention about 5th year is that it's almost like slightly done in an opposite way round of like you learn renal in 4th year, which is all of the kind of weird and wonderful stuff, which is fantastic. I love the weird and wonderful stuff, but much more common is the urology side of it. So the stones, bladder cancer, prostate cancer, that kind of stuff as causes of hematuria. So that will be much more your focus this year and should be higher in your differential. Another thing to point out when you're in A&E is it's very, very important to ask any suitable patient if they're currently menstruating, because so often you'll get like plus of blood and think, oh my God, you know, something really interesting, and they're just menstruating. So it's always worth just double checking. Obviously, if they have other features that might indicate a nephritic syndrome or a stone or something else, then obviously you can't put that down just to menstruation, but it's something just to bear in mind when you've got a very reassuring picture. You don't want to go down the avenue of doing invasive tests when it could just be simply explained by this. Cool. So which of the following investigations is the gold standard for the detection of renal or ureteric stones? Okay, so we've got a couple of C's. Yeah, you guys are literally smashing it this evening. So yeah, it's the CT-KUB and it's without contrast. And this is like one of the few indications to do a CT abdo basically without contrast. So other things you would do with contrast. So for your bowel cancers, for your bowel perfs, that kind of stuff, you would do it with contrast. With this, you don't. And so that's something else to bear in mind, is that if someone's got an AKI and you know, they're kind of worrying, you're worrying about, you don't use contrast for this, so that's not a consideration. What are the other indications for no contrast? I'll have a think. I'll get back to you. I mean, from looking at them in A&E, you can, if there's other pathology that's quite obvious, you can still see it without contrast. So if they've got a whopping great big tumor somewhere, you can still see it. But obviously with contrast gives you much better image quality for other pathologies. And so the CT-KUB isn't just kind of completely specific to look for kidney stones, but it's not like the best modality to make sure that you've not missed something else. But I will get back to you. And then obviously with anyone of childbearing age, you want to do a beta HCG before, because you don't want to expose them to radiation, and that can be quite a difficult decision to make, and where ultrasound can come in instead. Cool. So this was an actual case I saw last year. So there was a 29-year-old pregnant woman who presented with severe right-sided loin pain with fevers and rigors. She underwent, so because she was so unwell and they suspected a stone, they decided to do basically deliver her baby, who was fine, and then they went on to manage the stone, because for a number of reasons we'll go through in a bit, you can't really treat it while still being pregnant, and she was far enough along that it was reasonable. It was late third trimester. So they do an abdominal X-ray after they've taken baby out. I think in the real case they did an ultrasound, but like we're not going to do ultrasound. And so you see this appearance on an abdominal X-ray. Given that this stone, what is the most likely infection to have caused it? This is like a very classic kind of SBA. Wow, everyone is very unanimous. This is good. So yeah, it's B. So it's Proteus mirabilis, and this is a staghorn calculus. So all of the others are in your differential for a UTI, the most common being E. coli. But when you get Proteus in the urine, you've got quite a high concern, basically, for a staghorn calculus. Fantastic, cool. And so, yeah, these are the triple phosphate. They typically fill the calyces of the kidney, so they don't pass. They're just massive. And so they give this quite nice appearance, but are pretty rubbish to have. And they're slightly radio opaque, so you can usually pick them up. Cool. So you've got this lady. Let's just pull aside the pregnancy angle. If you just had someone who's got this stone and they've presented to the A&E department and they are in a lot of pain, what kind of things could we give them? Because this is kind of going to be your kind of first thing, is to try and settle them down a bit and give them something to take the edge off. So yeah, intramuscular diclofenac. Yeah, so yeah, PRIM. Yeah, so good. So diclofenac is the first go-to specifically for stones. I think it also helps relax the ureters. So probably not for a staghorn, but for like those smaller stones, it can help. And so yeah, we're going to do our diclofenac. Some of the patients might be vomiting as well, so you can pick whichever antibiotic you fancy. I think metoclopramide is sometimes recommended. I think cyclizine could also be another option. And usually, if the stone is small enough, so under 0.5 centimeters, you can just manage it expectantly and safety net, say come back if it doesn't improve. If it's a large stone, we're thinking this isn't going to come out, refer to urology. And if there's an infection, so a pyelonephritis, you're going to give antibiotics and you're going to send to urology. So if we take a simple stone, what might urology do? Like what are some of the interventions that they can use? And I wouldn't say like you have to give me like the really specific name. Like there's just kind of simple broad things they might do. So yeah, so if the stone's massive, rather than sort of pulling it out whole, they might have to fragment it. And yep, if there's loads of urine building up or there's an infection, they can decompress it, which we'll go through. They can stent the ureter open, so if it's stuck in the ureter, they can do that. And if they've got any strictures or any problem like that, you can do that as well. And then yeah, there's the shock waves. And so obviously, I kind of would bundle them into like there's a laser option, there's a laser option, there's an endoscopic option of fishing it out, and then there's like an open option if you're desperate. But like usually all of the other methods usually work. And that would be for something, an open would be for something quite complicated and very postgraduate level. So the shockwave option is very good. So they use ultrasound beams and they kind of blast the stone and fragment it. And so those fragments might come out on their own or they might fish them out. The main thing with this is that it's contraindicated in pregnant women and is something to remember. So for my lady, that wouldn't have been an option and you couldn't have done that. You didn't have that option. So they had to deliver and then they could use this to kind of remove bits of the staghorn calculus out. And then so it was mentioned before by Zach, so if in kind of combination with decompressing, you can also do the percutaneous route. So you go in and you fish the stones out of the kidney. So those are kind of the more proximal problems. Whereas if it's in the ureter, you can go endoscopically through ureteroscope and fish them out, or you can go like, open and do that. So what are the main complications if you've got an obstructing stone and you had to kind of use the medical terms? So like, what are the complications of an obstructing stone if we just left it and went and had a cup of tea for 4 days? So yeah, hydronephrosis. So you've got all that urine is not coming out. It's just going to swell the kidney up and it's going to be massive. You've got a load of stagnant urine sitting there, a load of infection sitting there. You can get pyelonephritis that can then go to sepsis. So people can die from this. So scarring of the kidneys, scarring of the ureters, and then obviously that can spiral into you being more prone to future ones as well. So we're not going to go and have a 4-day-old tea break. So the main complications mean that when we do get this situation, we want to decompress it. We want to remove that infection source. We want to remove that urine. And so they'll do a nephrostomy. So if you're on the wards, you'll see usually it's a posterior approach. So in their back, they'll have a tube. It's worth just seeing so you know what it looks like. And then the urine will collect in that bag. And once you've dealt with the stone or the primary problem, and it's not completely exclusive to stones, there's other reasons they might do it as well. There's other causes of a blockage. But for this, that will be what they'll do in the interim. And hydronephrosis is quite good to look up CT scans, what it looks like, because they could possibly give that as an image. I just think they'll give something quite, quite a severe case, but it basically looks like this. You get kind of this obliteration of like the medulla and the cortex of the kidney, and it just gets completely filled up with what looks like calyx. Cool. So you've sorted your patient out. She's going home. She's very happy. Baby's good. What things might you advise her in the future to prevent stones? And this is kind of, if we talk about all kinds of stones, what might be some things that you advise the patient? So yeah, keeping hydrated for sure. Yeah, because that also reduces the risk of UTIs as well. So if you've got a woman with recurrent UTIs, staying hydrated is good. There's not much evidence at all for cranberry juice, so I wouldn't go offering that in an OSCE. And then, yeah, depending on the composition, reduce the dietary intake. So reduce calcium intake if it's calcium stones, reduce uric acid if it's urate stones. What kinds of foods precipitate gout? Just as like a side note. It's kind of all the good foods, really. That's why all the kings got it and stuff. Yeah, so red meat, some lovely king prawns, glass of red wine, that kind of thing. So all the good stuff. So yeah, you'd advise them against that. Fantastic. And so it would also be that if they get symptoms again, to kind of come earlier as well, and get that under control. You can also alkalize the urine, which is slightly beyond my level of understanding, but that can also reduce the risk of getting the cystine and the urate stones. I think it alters how they precipitate, but that's slightly beyond my scope. And then you can use like thiazides as well to reduce the levels of calcium. So fantastic. And obviously if you've got like homocystinuria, there's not much you can do about that. So it might just be greater awareness. Cool. All right, so we're going to move on from urology slightly, and we're going to just touch on some renal pediatrics, just as a bit of a crossover. So Joshua is a 3-year-old boy who was brought to pediatric A&E by his parents following an episode of visible hematuria. You take a thorough history and ascertain that he has been having vague abdominal pain for the past few months, and he has a past history of having a hypospadia correction after birth, so he was born with his urethral meatus in the wrong place. Which of the which is the most likely renal malignancy he will be diagnosed with. And we've got neuroblastoma, clear cell carcinoma, renal cell carcinoma, Wilms tumor, and rhabdomyoma. And I wouldn't worry, like, if you haven't done peds yet, if you've not covered this, like, we're doing this because it's the, you know, these are some of the more awkward bits of pediatrics, which are quite new. So don't worry. That's why we're going to do it. So we've got 1 vote for D. What does everyone else think? Or maybe give 2 if you've kind of got it down to 2 and you're not sure. So D or A? I like your thinking. Yeah. Yeah. So that's good. Everyone's got it down to D or A in this age group, which is fantastic. And then, yeah, it's just, we'll go through the minutiae of which one's which. Fantastic. So, Jess, you were correct. It's a Wilms tumor, and we'll go through why that is. So, a Wilms tumor is a nephroblastoma. It's the most common renal tumor in pediatrics, and it covers about 9 or 10 of the cases that you get. It's the 4th most common type of cancer in children. So the most common is leukemia, followed by brain cancer, and then we'll go through the 3rd one in a sec. It usually presents under 5 years of age, at around 3 years of age, and survival is very good in general. And in a very small number, it's bilateral as well, and so it kind of gives this appearance. And yeah, it's from the renal parenchyma itself. And usually they'll present with abdominal pain, gross hematuria in some cases, recurrent UTIs. And the main thing is that it can go along with other congenital abnormalities. So if you've got a child with a varicocele or a hypospadia, or they have an undescended testes, that might be a bit more on your radar that they could have this alongside. And in females, they might have uterine abnormalities. They might also present hypertensive as well because of the renal disease. And just this shows, I think, like how big these can get because they have such vague symptoms that it really can sometimes take them to have a very distended abdomen, to be quite unwell for this to be picked up. And so this is what they look like. And that's the kind of white the sort of denser appearance of the Wilms tumor. And that's the normal kidney on the other side. Cool. So let's just continue. So this is like me being me with some like genetics, but it won't come up, but just in case maybe it, like, for some of you are interested or it makes you remember it. So it's related to certain abnormalities. It's also related to certain genetic diseases. Some of it's a bit unclear, but there's a few associated syndromes. So one of them is this like Wagger syndrome, which is they get a Wilms tumor. I put this on just because I've done a bit of Opthal recently and I found it really interesting. And if any of you are doing Dugelder, just in case. So they get an absence of their iris. So these kids can get an absent iris, Wilms tumors. And then you don't need to remember the other ones. You don't need to look them up unless you're like me. Then Edwards syndrome can get it as well. So usually this is in combination with some other things going on, I think, in an exam question is all I'm trying to get at. But like, don't feel like you need to know this. Cool. So that's our first one. Then we move on to another case. So this is a 4-month-old infant who presents to A&E with chronic diarrhea, failure to thrive, and abdominal distension. Your consultant suspects a malignancy originating from neural crest cells. What is the most likely location of the tumor? So everyone said A or D last time. So as we've covered D, it's probably going to be A. So does anyone know where the most common site is? And I think sometimes just think a little bit with your gut or rule some things out. So yeah, we've got some votes for C here, which is good. So yeah, it's C. So these are neural crest cells originating from the adrenal gland, and this is like an abdominal pathology. So fantastic. So this is neuroblastoma. They can metastasize to other abdominal lymph nodes. they're also obviously not, it's not just the adrenal glands. It can be in the thorax, it can be around the skull as well, but it's most commonly in the abdomen, I think. And this is the most common cancer of babies, so this will typically present under 18 months. It's the third most common childhood cancer overall. And basically you're thinking anywhere along the sympathetic chain. And because it's along the sympathetic chain, you can also get disruptions to that as well, so with associated symptoms. And just in case they are really cruel, which I don't think they would be, it's like there's pseudo rosettes on histology is what it looks like, so it looks quite pretty. There's a few other cancers that have these pseudo rosettes. I doubt that they will give it to you, but just in case it helps you remember, just in case we've got any like budding pathologists out there, which like there must be some. And so this condition can be picked up on ultrasound prenatally, so it can be picked up at the scans and the parents can be informed. Otherwise, it typically presents quite late because they can compensate quite well, and usually there's metastases at presentation. They can have raised catecholamine levels in the urine if it's in the adrenal glands, and generally it's got a poorer prognosis than a Wilms tumour, and generally it's a poorer prognosis the older the child is as well. And that could be that it's presented a lot later as well for those kids. And I've just got a diagram here which kind of shows the slightly different presentation of the two. So Wilms, it's going to be in the actual parenchyma, and then a neuroblastoma is kind of going to be over it. It's going to have that appearance as well. If anyone has any questions, like let me know. I used to find this stuff quite difficult to get my head around, but I think it is worth knowing which are the most common cancers in kids and the ways that they can present as well. But I think they'll have much more of a focus on like leukemia as well, but you never know. Okay, so an 8-year-old child undergoes an abdominal ultrasound following referral due to palpable abdominal masses and renal failure. Given the most likely diagnosis, which of the following statements is true? It is the most common renal cancer in childhood. The condition has autosomal dominant inheritance. First-line treatment is radical nephrectomy. First-line treatment is multi-chemotherapy regimen, and the condition has autosomal recessive inheritance. And I said earlier there'd be no ultrasounds, but I lied. So. Okay, we've got a bit more of a mix. So we're between B and E, which is again the right shout. So what are we thinking of? Like what is this showing us? Yeah, so polycystic kidneys, right? Does anyone remember how different types present? So autosomal recessive versus dominant, because that slightly gives you a hint. So yeah, so autosomal dominant PKD presents later. So it's typically in adults, so like 20 years onwards, about 30 years. And the recessive version typically presents in childhood, and they die in childhood. So that's why the autosomal recessive is the best answer here. So just when you between two, just have a think about the age of onset, because otherwise they're quite similar. Can anyone else tell me like the other complications that these patients can get? That's something to think about. So yeah, they can get subarachnoid hemorrhages, and yep, it's because of berry aneurysms. So that's another problem that they can get, and you will screen for that if they have an affected relative or two relatives. So that's something else that they can get. Fantastic. So I've somehow shot through quite a lot in half an hour, which I wasn't expecting. So we'll go on to some of my extra slides and then we'll just do a couple of other talking points. So one of these I've sort of given away from what we've literally just spoken about, but does anyone else know what these other images show, which are congenital disorders of the kidney? So yeah, the middle one is the horseshoe kidney. So it's kind of fused and it sits around here. Good. Does anyone know what like this might? It's kind of on similar lines to polycystic, but it's not quite. Yeah, so it's they're bigger cysts, they're kind of more defined. And so this is the multicystic dysplastic kidney. So the kidney is mostly made up of these big cysts and it doesn't work properly. And so they can present with like renal failure earlier in life. And a horseshoe kidney generally makes you more likely to get problems with obstruction, renal failure, those kinds of problems. And you'd be surprised. I think we had one on the urology ward last year, so they are like worth seeing. And then I'm not going to go through them too much today, but it's worth just having a flavour of the different congenital abnormalities that you can get with the ureters and with the kidneys. So the difference between, hold on one second, let me have a look. The difference between multicystic dysplastic kidney, I think it has much less of a genetic basis and more of just a congenital abnormality basis. Let's have a look. I'm sure there are some genetic conditions that will be associated, but it's usually just they don't form properly. So let's have a look. So it can be genetic syndromes, and it can be sometimes has been precipitated by medications. And it's to do with the induction of the metanephric mesenchyme, which again is too first year for me. But I would say that ADPKD is very much like its own specific genetic entity, its own genetic disease with its own mutation, whereas multicystic dysplastic can have a few different causes. I hope that has answered it okay. And so, yeah, the other things to think about are the other things that can go wrong. So you've just got a kidney that hasn't formed properly and is small. You've got this multicystic kidney which doesn't work properly that looks like this. You've got a duplex kidney, which is where you've got two ureters coming out of it. So you've got one here and one here, and you can get dilation and blockage. You can get vesicoureteric reflux, which can cause a lot of problems. So you can see the dilated ureters there as well. And you can see then get general obstructions, and also posterior urethral valves can happen as well. And so those could be like just worth just being aware of. Okay, so let me have a think about what next to cover. Give me 1 second, because yeah, I was not banking on being so efficient. It's not usually my style. Okay, 1 sec. Let me have a think, because I've got loads of backup stuff. If anyone has any questions in the meantime, let me know. But otherwise, I'll get some stuff up. So hopefully my animation should work. Okay, cool. So I've got a more peds PowerPoint, so we can like do a bit of a see what we get through, a bit of a pick and mix. I hope that's okay. If anyone would prefer more urology, I will be doing some next time. Okay. Just keeping you guys on your toes. No, I'm genuinely keeping myself on my toes because I'm hoping I actually remember what I've put. So I think with urology, it's quite simple. It's where's the blockage, that kind of thing. So it will be one of the easier ones to revise, in all honesty. I think you guys will be fine. You guys already seem to know your stuff very well. And I think knowing the 2-week wait pathways for bladder and prostate cancer is also a really good thing to do. Right, so let me see if my animations work. Okay, so pictures. This is just going to be pictures, so it's quite a nice way to end. So does anyone know what either of these are showing? They're two different pathologies. Yep, good. So one of them's a port wine stain. So I'm assuming you're thinking the bottom ones. That is a port wine stain. Fantastic. Or it's just like a vascular malformation, but yeah, port wine stain. And then that is a strawberry nevus, which is also called a capillary hemangioma, or a cavernous hemangioma. Fantastic. And so usually with the capillaries, they're solitary, they're mostly on the head or neck, and usually they will just get bigger and then they will slowly shrink away into nothing. We sometimes treat if they're near the eye, that kind of stuff, and if they get big, they're going to cause problems, but otherwise we're not too worried. And then with the port wine stains and stuff, they just stay, and they can appear bigger as the face gets bigger, but generally like they stay about the same size. Cool. Okay, onwards. So you've got these rashes as well. They're not really rashes. Yeah. So yep, cafe au lait is the bottom picture. On the bottom, or the bottom picture. Yeah, it's the bottom picture. And then yeah, a Mongolian blue spot, which might have changed name because it's not particularly politically correct, but for now we'll go with that. Good. Do we worry about Mongolian blue spots? And who normally gets them? Which groups of patients? So yeah, you note it down for safeguarding so that if they come back in, it's already been documented. And so, you can be kind of aware that it's not an injury. And yeah, so it's babies with darker skin tones that normally get these. And you reassure they will go away. And it's usually just that they get the entrapment of melanocytes in the dermis. And they can be massive if you go on the internet, like there's some quite impressive ones, but they usually just regress. And then cafe au lait spots, so who can get those? It's now called dermal melanocytosis. Cool. That is what we will use in future. These were my slides from last year, so I haven't gone through them in a while. So yeah, so cafe au lait spots, they can just be that you've got one. And if they've got one, you probably wouldn't be that concerned. It's if they've got lots and lots that you can be worried. And then the specific genetic conditions, tubular sclerosis, and what's the other one? Yep, so neurofibromatosis type 1. And so in general, these are usually in populations with darker skin. And so if you've got a lighter skinned individual, it might suggest more a genetic condition, but it's usually that there will be multiple of them. And they are flat, hypopigmented patches. And usually they sort of develop over the first few years of their life, so you won't see them kind of immediately. Cool. Okay, we've got some really random ones coming up, so I am sorry. I seem to have grouped things in slightly weird collections. So there's not really a theme going on here. So a baby has been born and it's got this red face with this kind of pustules on it. Does anyone know what that's called? And it sounds like really, really scary, and it's actually completely fine. It's got like the most melodramatic name for something that is pretty benign. This might be like, may not be spoken about. So you could worry about scalded skin syndrome, which is caused by what? I think I went through it a few weeks ago. So yeah, staph streps can do it as well. So yeah, scalded skin syndrome is like a possibility. Let's say that this kid is otherwise fine. It's only about 2 weeks old, hasn't been kind of doing anything, too wild. So the actual thing that we're looking for is this. They can get it's called an erythema toxicum neonatorum, which is like sounds so dramatic, but it's basically like neonatal urticaria. So in the first couple of weeks of life, they can get this kind of slightly red, angry appearance of the skin, and it goes away. So we reassure. I think with staph scalded skin, you might worry about maybe a bit further on after birth, and with some systemic upset as well. And then this one was just to highlight that like milia are also very common. And so these are just benign cysts. Lots of people get them, some people more than others. And they can be on infants as well. So they might be another thing that the parent is worried about. And they usually cluster around eyes, cheeks, lips, that kind of area. And usually you just reassure, and it's, yeah. Cool. Okay, let me pick another one. Okay, cool. So you have a child that is brought in by mama, who has these features and is unwell. What would be our differentials? And honestly, like I thought, would they give you a picture? And in the exams, they've genuinely given you like that much of a rash and been like, given the most likely diagnosis, what's the treatment? With like no vignette. So I think looking at photos can really help solidify it in your memory. So if people aren't sure of the diagnosis, just tell me some features that you can see, like from these images. Okay, so yeah, measles we could be worried about with any rash that looks like that. So, and obviously it's notifiable, and we would ask about vaccinations. What are the kind of other things that would really clench the diagnosis of measles? And sometimes it's useful to know like how they spread as well, like across the body. Yep. So in measles, they might have conjunctivitis, and then the Koplik spots. So they're the white spots in the mouth and the mucous membrane will be like the kind of clencher. And then the measles spreads. It spreads almost down, so it spreads from like the neck to the trunk. And they can get neuropathy and be very unwell. It's worth just noting, just reading up, and you hardly need to read up on it. There was a case at one of the hospitals I was at where one of the very rare complications of measles is that in something like 1 in 20,000 can get this leukoencephalopathy and can cause like basically decay of the brain years and years down the line. So it's not like this indolent problem. and it can cause like respiratory distress and death that way in kids. It can cause otitis media, that kind of thing. Okay, so this isn't measles, but we should always have it on our radar, especially in London. And I think Camden's got like one of the worst vaccination rates, actually. Okay, Kawasaki. So that's a good shout. So we've got a strawberry tongue here. And we've got a rash. So if this kid had recently had an upper respiratory tract infection or something like that and developed this, then we can think about Kawasaki. What's the treatment for Kawasaki? It's worth just there's something kind of on the to-do list just to know like the criteria for diagnosing it, which I don't know off the top of my head, if I'm honest. So yeah, it's one of the few indications for aspirin. Otherwise, you don't want to go there in kids because of the risk of Ray's syndrome. So they get encephalopathy and liver damage. And you can also do intravenous immunoglobulins as well. Fantastic. Okay, so it's not Kawasaki, it's not measles. If you've got a kid who's got strawberry tongue and they've got this slightly red-cheeked appearance and a rash, what's another infection you could think about? And this is a notifiable disease. Yeah, so this is scarlet fever. Yeah, well done. So it's caused by strep pyogenes, and they'll get this pharyngitis, this fever, and that kind of appearance, and it will be a white strawberry tongue, whereas I think in Kawasaki it's red strawberry tongue. Bit minutiae, but might help you. And they can get, I've put a few really like posts, so I wouldn't worry too much like about this level of detail. I think I went a bit overboard, and I've just kind of plucked these slides out of the bank, so you don't need to take everything, but in general they'll have this circular basically palate, like this absence around the mouth as well, so that's another thing to look out for. And generally their skin can also desquamate as well, and they need to be off school. And obviously we worry about strep infections as well, so we'll give antibiotics. Cool. Okay, so a bit of a throwback to something I talked about a few weeks ago, or months ago actually. What's this? Yes, this is impetigo. What causes impetigo? And how might we describe this? If they show it to you on an Oscar, what might you say? So yeah, staph, good. Staph or strep, but mostly staph. And yeah, honey-crusted lesions, crusty and golden, literally quite gross actually. And and it can come as like non-bullous or bullous, so that's the bullous form. And yeah, fantastic. And so if there's different treatments depending on whether they are systemically unwell or not. You can kind of start off with basic things like fusidic acid and things like that, and then you can move to antibiotics if you want. I won't go over this again in particular detail, but there's like previous presentation on the YouTube channel if you want a bit of revision, and a few other, I've covered some more of the kind of staph stuff as well. Cool. Let's go for a slightly trickier one. So this child has a rash, and this is showing a complication of this condition, which is like a pneumonia, but like it's got a few kind of slight opacities, but it's not very specific. It wouldn't be the sort of thing they'd give on your own, but one of the problems they can get is a pneumonia. And then they've got these lesions, which I will say are vesicular and raised and very itchy. And they will usually get a fever first, and then this rash will pop up. And I'm not going to say the thing that will clench it, because it will clench it. It'll be too obvious. So yeah, this is chickenpox. Yeah, brilliant. So I was about to say we've all probably had it, which would have just given the whole game away. So yeah, this is chickenpox caused by varicella zoster, which everyone knows about. You can get the reactivation, which is shingles, and that's in the single dermatome and very, very painful. It's spread by respiratory droplets and very easily between children. It's generally a much milder disease in children, and so we very much worry about it in adults, especially pregnant women. And so if a woman has been exposed, we go down the prophylactic route. They've not been exposed in the past. I went through that previously, so feel free. It's all in the same lecture. And so for kids, it's all about avoiding the scratching because you get scarring, like what I've got because I'm an idiot. And they can also get secondary bacterial infections afterwards. So you might consider some antibiotic ointment and things like that if they've got a secondary thing. But otherwise, this is very self-limiting. And very rarely it can cause things like encephalitis and problems like that. But those are more in the immunocompromised patients. And usually for most kids like this is a transient thing that isn't a problem. Okay, so this is quite a good one. So this is, maybe it's not a good, hold on. Some of these are at a push. So let me have a think. So this is a, this is an infection that is something we very much worry about in pregnancy because it can cause a lot of problems to the fetus. It is something that we vaccinate for, and it's in probably one of the most controversial vaccines, which is falsely controversial. So yeah, this is rubella. So this is the rash of rubella, and they can get that. What are the problems? What does rubella cause in the fetus that's so catastrophic? And the main thing to remember is that, like, you test the mother for antibodies, and if she's not vaccinated, it's not really the risk for her, it's more for the fetus in that case, which is quite different to the other infections, which can be quite detrimental to the mother as well. So yeah, they can get deafness, which is the most common. So it's a sensory neural deafness. They can also get cataracts. Cataracts is what they can get. So fantastic. Congenital heart defects is always a shout, usually with any infection. And it's so high. I mean, if it occurs before 10 weeks gestation, it's like 90% risk. So it's something definitely you'd have to pick up, and like someone very senior would like advise them on. And so it's not a good infection to have. Okay. All right, we've got two very sad looking girls who are very seem very like upset, which is understandable. So this infection gives this appearance, and I'll see if anyone's got any ideas, and we'll probably stop after this because it's 7. So yeah, this is slap cheek, and this is parvovirus B19. Fantastic. Are these girls infectious? Now that they've got the rash, it's a bit of a leading question. No, so they can go back to school. So it's the week before when they're completely asymptomatic, which makes this very, very concerning. And the usual vignette will be like a mother's come in, she's pregnant, her child's got it. And so you've kind of got to go through that rigmarole. Why do we worry about it? What's the complication if a pregnant woman gets parvovirus? So yeah, fetal death or like hydrops fetalis. Yeah. Who else is really at risk of if they get parvovirus? It's like really not a good it's really not a good situation. Yeah, so sickle cell, and then like immunocompromised as well. They can get a much worse scenario, and the other hereditary hemoglobinopathies and things, and the disorders of the cell wall, so like spherocytosis, that kind of thing. And obviously, if you're already at quite an anemic baseline, to then drop that even further is quite bad. So anyone who's systemically unwell as well. And so yeah, it's also called fifth disease, and it's typically in those kind of children in primary school, and it's spread by droplets. And those are like the things that we really worry about. And it destroys the reticulocytes. Cool. Okay, we'll do one. We'll do one more. One more because I accidentally clicked on it. Yeah, so I put up some hands, I put up some feet, and I put up a mouth. So it's hand, foot, and mouth disease. Does anyone know what causes this? Oh, nice. Yeah, I think Coxsackie is HS. Is the herb? Is it? I don't think it is. No, it's not. It's an enterovirus. Yeah, it's an enterovirus. Sorry. So yeah, this is Coxsackie A virus. It's an enterovirus, so it's also like quite a big cause of viral meningitis as well. As a side note, no one cares which family it's from. The majority is usually very young kids, and they just feel a bit rubbish, and then they get these vesicles that are very isolated, so they're not widespread like chickenpox. And usually they're not itchy as well. It's like the other main thing, they're not itchy. And yeah, it can cause aseptic meningitis or viral meningitis. And usually it's clinical diagnosis, and you just supportive, they can go back to school, that kind of stuff. So yeah, that is hand, foot, and mouth disease. Cool. Don't worry, we're not going to do all the 96 slides, which is a picture quiz that I did for my friends last year. Happy to do them at another time though, like a few of them. But yeah, I hope that's been useful. That was a bit impromptu, so like sorry. I can do some more urology next time. Let me just stop recording, and I'll take any questions.